All right, so we're really excited to deal with a different issue. We had a meeting about this, or this was incorporated into our CME course last year, where we had our first discussion about moving even further towards treating youngsters by looking in utero and seeing whether or not we can begin to understand, diagnose patients, identify times of treatment, and even begin thinking about treating patients in utero. But the first order of business in that is we need to have a better way of capturing fetal cases that are being diagnosed and begin to assemble data on that. So I'm very interested in this and very excited and very pleased to have Yair Blumenfeld back to kind of give us an update on that issue about prenatal diagnosis and monitoring and management. So Yair, thanks for coming.
Thank you so much, John, and the organizing committee for having me back here. And I look forward to hearing what my co-presenter for this session has to present as well. My name is Yair Blumenfeld. I'm an OBGYN by training. I don't do any more gynecology. My focus is on high-risk pregnancy, and my passion is really fetal medicine and fetal therapy. So this is becoming more and more in my wheelhouse. Don't have a lot of time, but my objective for this is giving you guys an update about screening for SMA. And sitting here in the previous presentation and learning that some states in the union don't even perform newborn screening gave me palpitations, and hopefully I can reassure some of you about updates in prenatal screening beyond newborn screening. Talk about what global fetal therapy considerations are as we're thinking about what an in utero therapy would be. And some of this was discussed, I think, in previous talks, but I think just honing in on two patients when you're dealing with pregnancy. What is known about the developing fetus in SMA cases? Not a lot, but I'll regurgitate some of the data I presented last year. And then we recently conducted a survey of the centers within the North American Fetal Therapy Network, which is a rapidly growing network within the United States. It now has more than 45 fetal centers, and these are the leading programs that hopefully I can impart on you would be an ideal candidate consortium to conduct any future in utero SMA therapy trial. And so I know everybody here knows that ACOG, the American College of Obstetricians and Gynecologists, and almost any other prenatal society, genetic societies, et cetera, recommend prenatal screening and have done that for well over a decade now. I don't need to inform this group about the implications of SMA nor the carrier frequency. And similarly, I don't need to inform this group about existing biological therapies in children. But really, while all these have shown to have benefit in neonates and children, none have really been studied extensively or really almost at all in utero and to see what the benefits are. And we know that from some cases, some of these children are born already with deficits, suggesting that there may be an opportunity to treat in utero, or at least a clinical benefit for doing so. What do we know about the experience of what a fetus with SMA does in utero? Well, there are several reports in the literature, not too many recently, by the way, and it started even over 20 years ago when people described decreasing fetal movement in utero in SMA cases, suggesting that early on in pregnancy, there may be normal fetal movement which decreases over time, and that might be a tractable marker of disease progression in utero. And this is an example of another study from 2011 of both SMA carriers and proven SMA cases, and all those had normal movement early on, and some of them had decreased movement later on. Another case series that showed decreased movement in the third trimester. And we have some experience with this, and in our experience, again, limited, unpublished, we actually saw normal movement, although we weren't really tracking it specifically. So, there's a lot of recall bias in these studies and more work that needs to be done. a little bit about where the landscape is now for carrier screening. I showed you that, and many of you guys are aware that the societies have recommended screening for SMA for well over a decade, but we know that the uptake has been quite slow. Obstetricians and other pregnancy providers historically have been honed in on Down syndrome screening and aneuploidy screening, and not so much on genetic disorders like SMA or cystic fibrosis. But recently we've seen a really rapid uptake in what's called expanded carrier screening. For those people who are not aware, I'm sure there aren't too many. Historically, the focus was, let's say, on CF and SMA and aneuploidy, and really carrier screening was targeted at specific populations. So for example, African Americans were offered sickle cell screening, Ashkenazi Jews were offered Ashkenazi Jewish panels, et cetera, et cetera. And expanded carrier screening was something that's been around now for about 10 years, but we've seen a rapid uptake in expanded carrier screening. And it's really, the goal is to screen pregnant women with over 100 diseases at a single time within a sort of unbiased way. So irrespective of your ethnicity or racial makeup, you get offered, everything under the sun. And we saw an uptake initially actually in the REI world, where couples presenting for IVF were screened ubiquitously. And I would say over the last 3 years, we've seen a really rapid movement towards the in utero world. And what I included here on the right is a slide that shows you sort of various tiers of menus, if you will, where pregnant patients are offered expanded carrier screening. And there's really some debate within societies as to which genes or which diseases should be included in these carrier panels. And there's different tiers based on expected allele frequency, and a lot of studies looking at efficacy and whether it's useful to do that. But the point is, what you're seeing here where it says tier 1 right over here, there's no disagreement that SMA should be included in whatever carrier screening paradigm you include. So again, another sort of focus on SMA, even as we're looking at expanded carrier screening beyond SMA. And just to show the benefit of using expanded carrier screening, this is a cohort out of Israel where they looked at their population, or a large population, before expanded carrier screening and after expanded carrier screening. And you can see that the introduction of expanded carrier screening dramatically increased the number of prenatally diagnosed SMA cases that they had. And there are some other examples of this in the literature. I was talking to John right before this about cell-free DNA. And so for people who are not aware in this room or have never heard about this, this is a way that is now almost universally used, at least in the developed world, to screen for fetal aneuploidy, testing maternal blood, looking for fragments of fetal DNA, and using counting statistics or other methods to determine whether or not a fetus usually has an extra chromosome in the case of Down syndrome. And people are looking at ways of expanding cell-free DNA technology to include single gene diseases. And this is an example of a study looking at cell-free DNA technology to identify fetal SMA. There aren't too many reports in the literature about this, but there's clearly an interest in utilizing cell-free DNA to diagnose fetal SMA as well. So clearly we're looking at a time, if you will, where there's an increased likelihood that SMA will be identified by carrier screening, and we have non-invasive ways of diagnosing SMA, or potentially non-invasive way, which brings us to fetal therapy and the different considerations that we should have if we're going to consider in utero therapy. So general global considerations for fetal therapy when you have two patients, and invariably, no matter what the therapy is, most of the time we're placing moms in harm's way to try to get to the fetus, even with minimally invasive therapy. So the general guideline is that if you're going to do that, the disease that you're targeting in the fetus should generally be thought of as severe enough to cause either significant morbidity or mortality risk, that the proposed therapy should have, ideally, of course, certainly low mortality, but even low morbidity to the mother, and that there should be some idea, and I didn't include this here, from some translational models as well. And obviously, if anything is done, usually initially it should be under research with appropriate oversight both from institutional review boards, data safety monitoring boards, ethicists, et cetera. Oftentimes there is disagreement among people in the fetal therapy world about whether there's equipoise and whether the therapy is actually useful or should be done. And even when there's concern about equipoise, sort of the general guidelines are there to suggest that if the disease is really, really severe, it's even worth trying or reasonable to try as long as there's likelihood that there may be some benefit to the fetus and that the harm to the mother is not significant. So there are certainly guidelines to suggest that even if there's disagreement, we see it now with other conditions, that there is some ethical framework to allow centers to do this under appropriate oversight and research umbrella. If we think historically about in utero therapy, the sort of initial targets were structural birth diseases. So structural birth diseases affect about 3 to 4%, or structural birth defects affect 3 to 4% of all pregnancies. Here you see an example of fetal spina bifida. Obviously a pretty invasive therapy to try to get to the fetus, where in this particular view you're looking at open fetal surgery where maternal abdomen is open and the uterus is exposed and the uterus is open just to get to the fetus. Obviously we have more minimally invasive ways of doing this now with operative fetoscopy or needle-guided procedures. But the point is really the right-hand side of this slide, and you're seeing guidelines from, in this case, our society, the Society for Maternal Fetal Medicine, where clearly there's a shift now to treating not just structural birth defects, but really genetic and metabolic conditions. And you can see top of the chart, right smack over there, is SMA. So clearly there's an interest not just amongst centers or individuals, but even societies at large to try to tackle this problem of treating genetic diseases in utero. This is an example, obviously, of a more minimally invasive way of getting to the fetus. This is a route of administering usually blood or blood products, where a needle is inserted into the umbilical vein in order to reach the baby. And here it's hard to see the needle, but this is into the fetal liver. So there are mechanisms of getting into a developing fetus in a minimally invasive way, as we're starting to think about which therapies we want to include. And so what we wanted to do, about a year ago, we felt that there was missing data or lack of data about really the incidence that our colleagues at leading fetal centers in the United States, the incidence with which they are seeing SMA, because most of these fetal centers deal predominantly with the treatment of structural birth defects, and we wanted to survey them to see their experience with in utero SMA. And so we obtained IRB approval, and we performed a survey-based study asking them about their screening, about screening in their region, about whether they're getting these cases referred to them, and what their approach is. And we asked the fetal therapy centers to get together with their MFMs, their genetic counselors, and their pediatricians to answer the survey. And these were the results. This is unpublished, but we're working on a short letter. So of the 45 NAFNET centers, about 60% responded, pretty wide geographic diversity in the United States. 60% said that OB providers in their region screened for SMA. So this gives me some reassurance for the states like Nevada, not to pick on Nevada, which was mentioned earlier about the lack of newborn screening. Hopefully these cases are being detected by expanded carrier screening. 96% said that if a case was identified in their region, it would be referred to their fetal center and not to a different program. And then 60% said they were referred at least 5 positive SMA carrier women who were pregnant to their center, and you can see that 44% stated they had more than 10 cases over the last 5 years. And this is really interesting that about a quarter of them said they managed at least 3 confirmed prenatal SMA cases over the 5 years. So these were cases that were diagnosed in utero, and about 1 in 10 identified at least 5 centers, at least 5 cases during that time. So NAFNET centers are being referred in utero SMA cases. Among those offering therapy, you can see the different therapies that they use, not in utero, but among children. And then the last line is really the crux of the issue, and that we were excited about, that of the responders, 18 centers said that they would be interested and have the resources to participate in a multi-site in utero SMA fetal therapy trial. And you can see their geographic diversity here. So we think that in the near future, if we consider something like this, we can leverage the network to do so. So despite the relatively low incidence of SMA, we saw that 60% of the centers studied are interested in participating, and our conclusion was that NAFNET seems to be an appropriate consortium if something was going to be tried in the United States. So our next step is really to perform sort of a natural history study where we're targeting fetal movement in SMA cases to help identify whether there's a therapeutic window in terms of the gestational age that we can potentially utilize in utero therapy. We want to know where that is broadly speaking, and to see whether we can target that gestational age for any future therapy. We obviously are looking to collaborate not just among NAFNET, but with other SMA consortiums, such as people in this audience, and to explore what the ideal therapy might be. Clearly, there's a moving target based on my listening to the previous session. So our initial hypothesis was that prenatally diagnosed SMA cases are referred to NAFNET centers, and we proved that. And our secondary hypothesis for the future prospective cohort trial is that we can identify an optimal therapeutic window for a future in utero therapy. So really, I think we're sort of at an inflection point where we're seeing rapid uptake of prenatal screening for SMA. So we think in the near future, more women will be identified as being at risk. I think we'll be able to diagnose definitive fetal SMA using non-invasive means. So we'll be able to screen for it, we'll be able to diagnose it better. The consortiums exist. We're seeing support for this from leading OB and genetic societies. But really the major questions remain: what's going to be the ideal initial fetal therapy, and is there an appropriate therapeutic window? And hopefully we'll be invited next year to talk more about that. So I'll leave that as a cliffhanger for now. So with that, we'll have my co-presenting Dr. Borges come and give us an update on their work at UCSF, and then we'll be happy to take questions at the end.
All right. Good morning, everyone. My name is Beltran Borges. I am a medical doctor by training, but I actually spent the last few years of my career doing my postdoc at Dr. Mackenzie's lab at UCSF. And today I'm also here on behalf of Dr. Charlotte Subner at Johns Hopkins University, with whom we have partnered to bring some of this data. We're going to change gears a little bit. I'm going to take in a little bit of a trip to the lab where we figure out some of these therapies that we've been talking about. So these are some of Dr. Mackenzie's disclosures. And my co-presenter already covered some of these, but fetal therapy has been around for several decades. It started in the 1980s when Dr. Mike Harrison performed the first open fetal surgery at UCSF. And throughout time, it has evolved through less invasive procedures, such as fetoscopic surgery and catheter-based interventions. But we also have fetal blood transfusions, which have also been around for several decades. But our team is trying to think of how can we repurpose this procedure that has been around to deliver stem cell transplants, enzyme replacement therapies, and gene therapies. And we call all these collectively fetal molecular therapies. So as a big overview, our group at UCSF, what we want to do is to treat severe congenital disorders prior to birth, with the dream of having initially deceased fetuses that are born healthy. And Dr. Mackenzie has been working for several decades on this, and she actually has 2 clinical trials for alpha thalassemia and lysosomal storage disorders. But we do really believe that the future of fetal therapy is in molecular therapies. So we're investigating different gene therapies for a variety of disorders, and some of those are spinal muscular atrophy and DMD. So some of the questions, why not wait until birth? The most obvious advantage is to prevent the onset of irreversible organ damage, but the fetus itself actually holds many benefits that we are very enthusiastic about. The first one is a permeable blood-brain barrier, so if we intervene during fetal development, we're able to target cells that might be more challenging to target later. And neurons in fetal development are still dividing and differentiating, whereas we think that if we intervene postnatally, they're already terminally differentiated, and there might be already some existing damage. The fetus has a unique immune system. We've been talking a lot about immunology this morning. So since its immune system is still developing, if you expose a fetus to a foreign antigen, it actually has the capacity sometimes to develop tolerance towards it, so it doesn't mount an immune response. We also have a very accessible stem cell population that it's rapidly dividing and it's primed for targeting. And you can imagine that a smaller fetal size involves a smaller dose, so this could potentially imply lower manufacturing costs. But for SMA specifically, we think that there are two reasons why prenatal therapy might be a good choice. The chart on the top shows you SMN protein expression throughout life, and you can see those green dots, which are the healthy controls. The peak of SMN protein expression is during fetal development, so this points towards the fact that this protein is important at this point, whereas the images in the bottom compare postnatal samples from humans, and you have a control which has a very healthy myelin axon, whereas we have SMA patients that have degenerating axons as pointed by the red arrows and the blue arrows. And the image most to the right is what a 14-week human fetal nerve looks like. And if you don't squint too hard, you can see that they're not that different from SMA patients. So we think that this points toward the evidence that when patients are born, there's already evidence of motor neuron damage. But if we try to take these therapies to the clinic, obviously we have to do a whole bunch of experiments, but we are not trying to reinvent the wheel, so we're playing with what's already available. We have ASO therapies, nusinersen, Zolgensma, and risdiplam. You'll know about them. And people have been studying prenatal therapies in mouse models for a while. We have small animal data in mice and large animal data, and what we're trying to do here is to fill the gaps, basically. You see there are already some papers published, and basically we're trying to do the rest. So I have this chart here that I'm going to keep recurring to for guidance, but you see that we have highlighted the mice ASO injections. So for these injections, we partnered with both Biogen and Ionis. And what we injected in these mice is actually an ASO that has the same mechanism of action as nusinersen, but it's tweaked in a little bit so it's more tolerable at high doses. And then us at the Mackenzie Lab at UCSF and in collaboration with UC Davis, we did practically the same experiment but in sheep, and then we also did some AAV experiments. So what the Summer Lab at Johns Hopkins did is they bred wild type, so regular healthy mice with SMA mice, and they injected them with an intraamniotic injection at E13.5, which is kind of like 2/3 through a mice gestation. And then these pregnancies were allowed to continue until birth, and some of these mice also received a postnatal injection. They assessed for a whole bunch of parameters: survival, weight gain, the rescue of the full-length mRNA. They quantified motor neurons in the spinal cord, and we also analyzed some behavior. And for those of you who might not be very familiar with the model, there's a little bit of a description of what this mouse model is. But what I want you to know that it has a transgenic insertion of the human SMN2 gene, so that allows us to test these therapies and assess their efficacy. So I'm going to show you a bunch of graphs. What they first look like is at survival. There's a lot of animals in this group, but first I want you to look at the blue and the black lines. You can see that the black are the SMA mice that did not receive an ASO therapy, and unfortunately they die very quickly after birth. Whereas the wild type or healthy mice, they have perfect survival and 100% chance of survival over 100 days. And then we have our experimental animals in the middle. And for simplicity purposes, I want you to try and compare the purple and the green, because the purple is the mice that received a prenatal and a postnatal injection of an ASO, which is most likely what would happen with a human patient. And then in green is the patient that only received a postnatal injection. We also have in red, mice that only received a prenatal injection for comparison. But you can see that although it's not a perfect likelihood of survival, the mice that received a prenatal and a postnatal injection in purple do trend very well. And we see the same thing with long-term weight progression. Again, in black, we see the untreated mice that die pretty quickly, but the mice in purple and in red, they're actually not that far off from the wild-type mice. We then wanted to know if this worked at the molecular level, so we assessed, does this ASO rescue the full-length SMN2 mRNA? So we looked in brains and spinal cords of both treated and untreated mice, and we saw that there was rescue of full-length SMN2 mRNA in the spinal cord. We quantified the amount of motor neurons in lumbar 1 spinal cord segment, and we saw that there were no significant differences between wild-type animals and the animals treated prenatally, so there's almost a full rescue in terms of numbers. But when we talk about untreated or those treated postnatally, there does seem to be significant differences. And lastly, we looked at behavioral rescue, and we have short-term and long-term behavioral rescue as these mice grow. The first thing that we look like is the time to write. For those of you who are not familiar with this test, it's basically we place the baby mice on its back, and we count the time that it takes for them to get with their forepaws on the surface as a measure of motor strength. You can see again that the mice in black do pretty poorly. It takes them 30 or more seconds. That's the cap that we measure to right themselves. More often than not, they don't even right themselves at all. And the data on this is not as strong as we would like it to be, but they're still work in progress, and you can see that the prenatally treated mice are somewhere in the middle. But when we follow these animals long term, we do see more of a difference between those treated postnatally and those treated prenatally. And I want to point your attention not only to the purple line and how close it is to the blue line, but also if you see at postnatal day 60, the red line is doing almost better than wild type or better than wild type. So this points towards the actual efficiency of a single prenatal injection and how much it rescues the phenotype. So the conclusions of these sets of experiments is that a prenatal ASO administration results in increased survival, an increased number of motor neurons in the spinal cord, excuse me, increased full-length SMN2 mRNA, and phenotypic rescue. And we wanted to take this one step forward in our lab and do it in large animals, because large animals, they're often a little bit better at predicting drug safety. Unfortunately, in sheep, we cannot measure efficacy because sheep only have a single copy of the SMN gene, so it's not the perfect model. But what we did, again in collaboration with UC Davis, is we bred sheep, and they have a gestation of 150 days, and we injected them at E75, so mid-gestation, roughly equivalent to the second trimester. We had 2 routes of injection, either directly into the intraamniotic fluid or an intracranial injection, which was done in collaboration with Dr. Gupta, who is a pediatric neurosurgeon at UCSF. And we measured safety and biodistribution parameters when we harvested these animals 3 weeks later at E96. We were very happy to see that these procedures are very well tolerated. We have a 100% survival rate in all our animals, and we do not see any significant differences in harvest weights, even when comparing for the different intraamniotic doses, which you can see listed there, or the differences in weight in fetuses based on the amount of number of fetuses per pregnancy. But since we're sort of trying to understand how ASOs behave in the amniotic fluid, we did a little bit of a chemistry experiment in which we measure the ASO concentrations before injection, 5 minutes after injection, and at the time of harvest 3 weeks later. We obviously saw the concentrations rise after injection, and they tended to trend down at the time of harvest, but there was one animal that you can see did not go down as much as the other ones. And as I show you the results in the tissues, you will see that one of these animals is lagging behind, and it's always this animal, although we're not able to pinpoint exactly why there was not as much uptake. We knew from studies from the companies that we partner with that a therapeutic range would be between 1 and 10, which is the green shaded area that you can see there. And we're very happy to see that both a 500 milligram and a 1,000 milligram dose are effective in reaching that concentration, whereas a 137 milligram dose seems to be ineffective. But we knew from previous studies in our lab with mice as well that when you inject an ASO into the amniotic fluid, it tends to go everywhere. And as you can see, we even achieved higher concentrations in the heart, lung, trachea, quadriceps. We think this is very encouraging for us. This could be applied for congenital disorders in the lung and for muscular dystrophy as well. But one thing that we did notice is the extremely high levels in the kidney, most likely because it's the mechanism of excretion and the amniotic fluid gets recirculated. So this could potentially be a source of toxicity. I do not have time to show this data today, but we did look at BUN, creatinine, liver function test, coagulation parameters, and we did not see any signs of toxicity. So to conclude the ASO experiment, we found therapeutic levels of ASO in the spinal cord, widespread biodistribution, and normal liver and kidney function tests. And for the last segment of my talk, I want to talk a little bit about some AAV or Zolgensma experiments that we did in fetal sheep as well. We partnered with Novartis to do this. And we actually got a vector that is very similar to Zolgensma, but instead of an SMN transgene, it's a GFP transgene. GFP is a green protein, so as I'm going to show you some pictures, I just want you to look for the green. And the way that we did this is kind of similar to what we did with the ASOs. We also injected these animals at E75, but we injected them either directly into the umbilical vein, which is the equivalent of an intravenous infusion postnatally, or intracranially again. And we harvested these animals at 3 weeks for long-term safety and at 3 months for, 3 weeks for short-term safety and 3 months for long-term safety. We looked at skeletal muscle, and as I told you, GFP equals green, so all that green that you see there in the muscle, it's very, very encouraging. And the purple is a component of the basal membrane, so it basically outlines each muscle cell individually. And some preliminary quantification experiments that I did show between 70 and 80% of muscle fibers being transduced when we inject prenatally. We looked at how much vector genome we could find in spinal cord tissues, so we found detectable levels, but the pictures show something even more promising. In this case, the pink marks neurons. That NUN is the nuclei of neurons. So I looked for large neurons in the anterior horn of the spinal cord, and those whitish cells that you can see there is the green and the pink overlapped on top of each other. So that means that the AAV is getting inside the motor neurons. And what was even more encouraging for us is to compare our values to the values that were reported in the 2 children that received Zolgensma that died and were analyzed postnatally. The values that were seen in this paper were between 0.1 and 1, which are similar to the values that we see in our animals. But you will see that I also placed a red box around gonads. This paper didn't necessarily explore in this, but it is something that I did go further in, and I want to show you that in just a second. But we've been talking about immunity, and I told you that one of the benefits of prenatal therapy is the capacity to remain tolerant to foreign antigens. So we injected these fetuses with a lot of GFP, and we were happy to see that there was no GFP antibodies. 3 months after the injection, 1974 is one of our sheep moms, and then A, B, C, and D is 4 fetuses. As you can see, none of them mounted an immune response. I think this is very encouraging. However, at least at this time of development, these sheep fetuses do mount an IgG immune response against the AAV9 capsid. And another caveat to show here is that the moms also mount an IgG response. So as Dr. Blumenfeld pointed out, it is important to also keep maternal safety in consideration here, and at least the mounting of an immune response by the moms points towards a certain degree of exposure for the moms. And in the fetus, although they did mount an immune response, one thing that we think is encouraging is that the titers that we saw are lower than the titers that were reported postnatally in a paper that came out earlier this year, and you can see that in the dotted line at the top of the graph. I told you that we looked at the gonads, so we checked and we did find vector genomes in the gonads, unfortunately, but the question was that is it in the germ cells or is it not in the germ cells? Because any prenatal therapy effort should be for somatic cells only. We do not want to touch the germ cells. And when I look at the male testes, I did find GFP positive cells, but these GFP positive cells were outside of the testes cords. Those pink cells that are DDX4 are male germ cells. So you can see that they do not overlap, signaling that male germ cells are not transduced by the virus. But in the females, unfortunately, the history is the opposite. We do see colocalization of the pink and the green. So this means that the virus is getting inside the female germ cells. And we did some bulk genome integration analysis, and we did find very low rates of AAV integration into the genome. Now, this for us is very important because if AAVs are used to deliver a gene editor, the fact that an AAV is able to get into a female germ cell means that as soon as you introduce that into a female patient, it's going to make edits in germ cells. So we have some ongoing therapies that ongoing efforts at UCSF to try to come up with vectors or gene editors that are not able to function in female germ cells, even if they get in there. But this still remains encouraging for X-linked disorders like Duchenne muscular dystrophy. So as a bunch of conclusions, we did see that a prenatal AAV administration achieves transduction of skeletal muscle in large spinal cord neurons with no anti-GFP antibody response, but with a positive anti-AAV9 capsid antibody response. So it's kind of an imperfect tolerance, and female but not male germ cell transduction. But to us, we really wanted to know, would the community be okay with this? These are pretty novel therapies. Fetal therapy is novel in and out of itself. So we asked parents and caretakers of patients with severe SMA, if they had another pregnancy, would they be willing to enroll in a phase 1 clinical trial for a fetal ASO therapy or a fetal gene therapy? And the majority of patients said yes, which we think is encouraging. And we did this study, which is already published in collaboration with Cure SMA. So I hope by now I've been able to convince you that there are multiple potential avenues for a prenatal therapy for SMA. That the sheep model, although imperfect, it allows us to test various routes and get an idea of what the safety and parameters that we need to look at. That an intraamniotic injection is a viable and minimally invasive route to deliver these ASOs prenatally. And that although the encouraging data with AAV9 GFP injections is encouraging, there are certain toxicities that we need to pay closer attention to and do more experiments and see if we see them again, perhaps with a lower dose. And there's also compelling preclinical data and patient engagement for future IND applications. This is Dr. McKenzie's lab, and this is, I was actually last night at a Christmas party. So I would like to thank Dr. McKenzie and Dr. Sumner for their mentorship, and happy to take any questions.
So we do have a couple of questions here. Maybe I'll have you take the first one, which is regarding distribution in a sheep model with oral therapy.
Yeah, that is a great point.
Maybe I didn't word the question well. Maybe you can.
Yeah, so the question says there has been at least a single fetal case treated with risdiplam orally administered to the mom. Would it be worth exploring this in the sheep models too, at least to determine PK and biodistribution? As I said at the beginning, we're kind of trying to fill the gaps of where the field is. So we really felt like there was some, like with Zolgensma and ASO, given the hit that they had, there was like some experiments missing on that end to try to pursue this further prenatally. But one caveat that we always have is that the placental structure of the sheep is not exactly the same as in humans. So sometimes it's hard to predict how those things would work when we try to model these experiments, but we're definitely thinking about it moving forward.
Yeah, I think the other three are rather quick related to, I think, my presentation. Just one thing about oral therapy, there is precedence of maternal oral therapy to try to get to the fetus, whether it's with fetal cardiac arrhythmias, and we recently had a case of cystic fibrosis where we administered a medication to the mother to get to the fetus. So there is precedent. Hopefully you guys move forward with that. Quick question about whether there are any Canadian centers in NAFNET. There are. There are 3 centers in Canada. There's one in Vancouver, one in Montreal, and one in Toronto, and there's actually at least one in Mexico as well. So it's truly North America, not just the United States. I'm sorry if I gave that impression. And then one question about whether prenatally diagnosed SMA pregnancies are being carried to term. I'm not sure if the person who asked that question means whether there's spontaneous preterm birth or other OB complications related to SMA. That remains to be seen, or whether this is related to pregnancy termination, and we don't have those data, whether they meant this or that. And then in terms of, there's one last question asking whether we really need to know whether there's a functional decline in utero and when it happens, or can we just treat everyone in the third trimester? I think it would be reasonable to have a better sense of when the decline happens. Sometimes we choose the timeline for in utero therapy based on feasibility, not necessarily just biological plausibility. There's some feasibility in terms of when patients get referred to you and how soon you can do the analysis. But I think trying to understand the science is always a worthwhile, or the biology to advance the science is a worthwhile goal. I think we're on time. I don't know if anybody has any other questions.
I was just asking whether or not there's any kind of determination for fetal therapies based on SMN2 copy numbers of the fetuses.
Maybe we'll start with any basic science answer to this. I can give you my.
Yeah, I don't know the answer to that off the top of my head. I mean, I do know that like with animal models, it's sometimes like difficult to predict because it's only NHPs that have the SMN2 genes, so the chance of the copies is kind of like a mute point sometimes. With most of the animal models that I have worked at least, that is kind of like a problem that we do not encounter because they don't have an SMN2 gene. So maybe you have a better point to make out of that.
Yeah, so two-part answer. One is we're definitely interested in that in a prospective study where we're actually going to get a lot of granular data about these pregnancies, so that's certainly going to be a part of that. The second part is a part of the survey, which I didn't include here, was asking the genetic counselors whether they've had any issues with getting copy number information from either CVS or amnio labs that they use. And for the most part, I think the responders were able to get that information prenatally, clinically. But it's certainly something we're interested in knowing, the copy number of these cases moving forward and what the implications are on in utero fetal movement.
Yeah, I mean, from a practical standpoint, from patients, when babies are born, and I've had the experience of having a prenatal couple come in to do carrier discussion and treatment of their baby, and had the long, big discussion, and their baby then was born and had 5 or more copies of SMN2, and that pretty much precluded treatment for that infant. So it's kind of a practical consideration as well.
No, absolutely.
One of the questions says, does germ cell transduction by AAV have to be 0 to be acceptable? Or how effective does the inactivation of the transgene have to be after transduction? So this is a great question that, ideally, yes, it would be 0. But it's not a reality, at least not until now, which is, at UCSF, the Cromer lab at UCSF is trying to design this AAV vector capsids, but also the gene editors themselves, or these gene replacement strategies. We're trying to design them in a way that if they do actually make their way into unintended target cells, such as the germ cells being the most important, they're non-functional. So that would be kind of one of the strategies that we're thinking about, while we're also seeing where the field goes instead of in terms of vector manufacturing to make them more safe and more specific. And then the second question is, are there ethical concerns about ASO affecting germ cells in the fetus, or would any effects be considered transient? That is a great question. ASOs are actually rapidly degraded, so their effect would be transitory. And they do not have a lot of nuclear interactions, so its effect would be more limited, and there wouldn't be genome editing concerns.